Thank you so much, Dr. Hoffmann-Byrd. When I came here as a student in the late 80s, I was very much interested in all fields of epidemiology, but not much was done in terms of the risk factors for dementia, in particular Alzheimer's dementia and also Parkinson's disease. And one of the best studies at that time that was done internationally was the Rotterdam study. And I was following the Rotterdam study, and Bert Hoffmann was the chairman of the Rotterdam study. And therefore, we knew before we ever met, as a matter of fact, because I was very aware of this important study, one of the first studies that showed the risk factors for Alzheimer's dementia. And we have just a couple of minutes ago discussed how the field has developed. But a lot of what was found in the Rotterdam study is still state of the knowledge as we speak. So therefore, that was pioneering work, and I would like to thank you for that leadership so many years ago. My topic today is elevating global health, the momentum of the UN high-level meeting, and everyone would initially think, why deal with such a dry matter? Why not, let's say, talk about studies like Alzheimer's studies, artificial intelligence, Mendelian randomization? Why not speak about, let's say, large trials which are going on? Why speak about the administrative language of UN meetings, which is often bloodless, which is often very abstract, which is often very difficult to understand? Why should someone like you waste time with such a topic? Well, in essence, first of all, when you look at UN priorities, health measures have not been at the top of the agenda for a very long period of time. There is different issues, for example, peacekeeping, very important. There is, let's say, international relations. There is, let's say, negotiations of trade and so forth. But health is not that big a topic for UN issues so far. And this is already important. And number two, it is also important because if you look what the priority of UN meetings become, this is very, very important for future funding decisions. So if a topic rises up on the agenda of UN meetings, it will rise up in terms of major funding decisions in the time to come. So therefore, for a public health person who wants to make a difference, it is often a better investment to deal with these issues than to deal with a single study. If you do a single study, it's an important study, but if a decision is made at that level, that could imply that 150 additional studies are funded. And there is no way that in a single study you could make a difference of the size of initiating 150 other studies that are done by people which are not much less qualified. So therefore, the impact that this language does have is enormous. And as a young epidemiologist, I was not aware of this. So I most likely, at a Friday afternoon, would not have come to today's meeting. With my current knowledge, I'm very pleased that you are more wise and more intelligent in this decision-making than I would have been 30 years ago. What is going on? In the UN, we currently have 3 major high-level meetings. High-level meetings are the kind of meetings where a consensus statement is the output. And in this consensus statements, basically it is announced what will be the priorities policy-wise and also research-wise in the years to come. And we have 3 such high-level meetings here, one on pandemic preparedness, prevention and response, one on universal health coverage, one on tuberculosis. And I'm going to speak about all of them. First of all, I would like to speak 1 minute in terms of what is Germany's role within global public health. Well, Germany has a special role in the following sense. Germany is very much oriented towards supporting multilateral agreements. Now you would think, who is not interested in that? I mean, isn't UN, let's say, language and UN negotiation all about multilateral agreements? No, it's not, as a matter of fact. Many agreements are bilateral agreements where one state supports another state, but there is a give and take between states. So therefore, the money that is available in total, which is available for multilateral agencies and investments, is actually declining, while bilateral agreements are becoming more prevalent. And Germany very strongly believes that multilateral agreements are very much needed. So Germany, whatever Germany does in that sphere, is mostly geared towards multilateral agreements. And I fully agree with this agenda, with this position. It is also a position which is independent from who is currently in charge of the government in Germany. At the moment, we have the best government after the Second World War in Germany. It's a traffic-light coalition with the Social Democrats, the Greens, and the Liberals. But even under the leadership of Angela Merkel, a conservative government, Germany was still oriented towards multilateralism. So Germany is geared towards multilateralism, independent who is currently, let's say, giving the government. And the core objectives are, let's say, that Germany wants to support the global health strategy 2020 to 2030. The global health strategy is meant to, let's say, follow a couple of goals which are delineated in a moment, but Germany therefore supports the WHO and the UN and the G7 and the G20 meetings in terms of, let's say, making the multilateralism work. And in 22, Germany was heading the G7 presidency, and in the healthcare system, I, at that time, announced 3 priorities of research. One was pandemic control, so future pandemic control. Number 2 was antimicrobial resistance, which is an increasing problem. And number 3 was climate change. And it was a major privilege for me. I came into office in December 21, and in 22, January 22, we assumed basically that role. So I was immediately in a position to derive these, let's say, priorities. What is also important, when you look at these consensus statements, they look dry, but as a matter of fact, these are statements which are ultimately the consensus of 193 member states. So that's a huge impact. If all member states sign the policy, that means, for example, more research money is coming in 193 states. That's quite considerable. And the consensus, therefore, has to be a consensus behind which all the states can basically convene. But it is always a historic opportunity to place a health issue high on the political agenda. And here you compete with other health agendas and with agendas outside of the healthcare field. So therefore, it's a unique opportunity. And it also will imply what is going next. For example, we have various cross-cutting themes across the political declarations on health. And the antimicrobial resistance, which is an issue now, will also be part of the UN high-level meeting next year. So we already have put that through G7 on the agenda for next year's UN health level meeting. And climate and health, which we put on the agenda for the G7 in 22, will be first ever on the agenda for the COP28 meeting in Dubai next year. So therefore, one priority makes it more likely that the same issue becomes a priority next year in another issue. And for example, it is remarkable, at least in my opinion, that climate and health has never been a priority in one of the COP meetings. And you would wonder, I mean, why would you care about climate change if you do not look at the health consequences? I mean, what's so bad about a couple of degrees more heat if it isn't for health consequences? But this is the first time ever that health issues will be a priority in one of the COP meetings. I quickly walk us through the declaration, and the declaration is currently finalized, but it is already in writing, so I can announce the results. The political agreement has come forward as of yesterday already. And for pandemic preparedness, the PPR meeting, the issues are, first of all, that there is a promotion of a One Health approach, acknowledging the impact of climate change. Number two, adequate funding for the pandemic fund and sufficient domestic public spending in PPR. And number three, advocating for the conclusion of the pandemic agreement for the international health regulations. And number four, access to medical countermeasures. Well, what does this imply technically? What does this language imply? Number one is, when it comes to One Health, the One Health approach implies that you look at the health of humans, animal health, and environmental health at the same time. Because we know that 75% of all new infectious diseases are of zoonotic origin. So what we do know is that, let's say, if climate is changing, we will have more and more pandemics. The risk of future pandemics will increase exponentially, because if there is more connection between zoonotic reservoirs and humans, and zoonotic reservoirs and companion animals, the likelihood of new zoonotic diseases goes up exponentially. And with climate change, we interrupt the habitat of wildlife zoonotic reservoirs, and we also increase the number of species living in the peri-urban region. So therefore, you basically get into a vicious circle, and this vicious circle makes it more likely that we will have more pandemics. So therefore, look at One Health approach is very important. And in this important paper by Leifels and others, it was quite clear that we have four strategies to address this problem. Number one is that we limit the wildlife domestic contact, which is very, very important, by fences, planning around migration routes, and so forth. Number two is that we identify and vaccinate high-risk groups. Number three is that we do routine testing of sentinel animals. We know for all of the diseases what are the sentinel animals. And number four, that we share the epidemiological data as quick as possible. So we do know what will work. And in that sense, following the old saying of the epidemiologist, brilliant, outbreaks we cannot avoid, they are mandatory, pandemics are optional. And if we get into that circle, we can basically avoid that outbreaks become pandemics, which is the One Health approach. And if the One Health approach is up here on the agenda, more money will flow for the One Health approach. More money, for example, will flow for the research, such as the research by Leifels, which is vastly underfunded. We have barely any funding for that important type of research. Number two, the pandemic fund. The pandemic fund was something that I introduced in 22 when we were having the G7 leadership. And it is an idea that was developed by Jeremy Farrar and me and a couple of people who were advising us at that time. And the pandemic fund is basically an educational fund, which currently is, let's say, 1.5 billion euros strong, where countries can get money if they educate epidemiologists in doing surveillance work and making surveillance work available internationally. So this is like a fire brigade that is educated in such countries where pandemics are most likely to origin. And you would have thought, well, we have these people in the field to begin with, but this is actually not the case. There is only a couple of hundred people who are specialists in terms of identifying new sources of pandemics, and they are, let's say, well-trained, but they do have many obligations, many jobs, and they do not concentrate on this type of work. So with the pandemic fund, we will basically educate a whole generation of pandemic experts who can do this type of surveillance work and are then in a position to work together and identify new sources of pandemics way more quickly. And the pandemic fund is, for me, a perfect example how something that starts with an idea and starts in language ultimately ends up to be money and ultimately ends up in researchers and students and ends up in a real change in pandemic control. So it all starts with ideas and language. And number three, the pandemic agreement. This is also very important. The pandemic agreement is basically an agreement which exactly explains what is the role of WHO, for example, if a new pandemic happens. There is a struggle internationally whether WHO should have a major role in pandemic control or whether more should be based on bilateral agreements and so forth. And the pandemic agreement clearly delineates who is responsible for what in case of a pandemic. Now you would think that must be known for decades. No, it's not. We don't have a good international agreement as of now, which explains exactly what kind of data are shared in what order and who is the owner of the data and in what ways these data are used. So that is also very important. And number four, many countries do not have enough medical countermeasures to contain the outbreak at the moment when it can still be contained and not become a pandemic. And these medical countermeasures you need access to. And number four of this, let's say, declaration, which is now has been finalized in New York as of yesterday. This basically explains in all of these four fields what is to be done. So therefore, I think this is a very important document on anyone's reading because it ultimately will channel billions of dollars and euro in better pandemic control on which we rely all. I will try to explain what this means in, let's say, have a last look on the, not a last look, but let's say a current look at what we know about the lasting impact of COVID when the pandemic is declared over. The pandemic is declared over, but for many people who have had COVID, the pandemic is far from over. In Germany, for example, we currently, roughly speaking, have between 1 million and 1.5 million people still suffering from the consequences of long COVID. So my reading of the US data is that you have a similar proportion of people suffering from long COVID. We have 250,000 patients suffering from ME/CFS as a result of long COVID. And we also by now have studies that show if long COVID symptoms do not clear in the first year, the likelihood of the symptoms to go away spontaneously at the end of year 2 is only 7%. So for most people that, let's say, are not able to clear long COVID symptoms after the first year, the likelihood of these symptoms to become chronic is extremely high. And the prognosis of a lot of this is actually quite worrisome, as a matter of fact. For example, we do know that COVID does damage to the endothelium. You see in almost all COVID sufferers, you see some damage to the endothelium, mostly, let's say, visible in tests like FMD, femoral medial dilatation. You can do other tests. In elderly, very often, you do not see full recovery on the endothelium. But you may think, so some endothelial function is gone, never mind. If there is full recovery, not much has happened. That is not the case. If your endothelium is damaged, all of the organs that heavily rely on endothelial function sustain a lasting damage. The organ to start with is the brain, as a matter of fact. So therefore, in, let's say, imaging devices with PET imaging, for example, SPECT imaging, or let's say functional magnetic resonance tomography, you basically see a worrisome reduction of blood flow and metabolism in the brains where endothelial function is to some degree destroyed as a consequence of the COVID infection, of long COVID. And that in the long run is expected to be a major risk factor for vascular dementia and also for Alzheimer's dementia. And therefore, if we have more and more waves of COVID, where according to some studies, for example, from Washington University, Professor Ali and others, where the damage is cumulative in recurrent infections, we have to worry about a tsunami possibly of future episodes of dementia, including Alzheimer's dementia. So that is a big issue. It has not been really dealt with. We also know that in the months after the infection, elderly people with the infection, even after infection, after vaccination, are at an increased risk of diabetes, cardiovascular disease, myocardial infarction, and also stroke. That is also quite substantial. In Germany, for example, in the third year in a row, we have a decline in life expectancy, which is by and large explained by the long-term consequences of a COVID infection. And we have new variants. So while the pandemic is declared over, we still have to struggle with the pandemic, and we do not exactly know how to prevent these consequences. We see a reduction. If you do very sensitive kidney tests, you see a decline in kidney function in those who had a longer episode of COVID. Now you may think, well, if kidney function in terms of GFR goes down by 5 or 10%, that is it's not a big issue. It's a major issue because decline in kidney function in the long run is a major risk factor, again, for dementia, a major risk factor for cardiovascular disease. It is an underestimated risk factor for many diseases, as a matter of fact. So therefore, all of the organs which depend on an intact endothelial function are at risk after a major long COVID episode or a COVID episode, even a post-COVID episode. So therefore, we have to really be prepared, and we have to be very, very vigilant in order to live up to the One Health approach. And the One Health approach was put on the agenda in this meeting. Show you this here. This is also a very good study. It's a study that shows how much more likely will it become in the future that we have cross-species viral transmission, for example, from bats into humans, or from, let's say, from small animals, wildlife animals, into humans in the next 50 years. And the modeling clearly shows if we do not decelerate and go on as we currently go on, we have viral sharing events in the millions per year. I mean, the upper graph basically shows in yellow, in green and yellow, the hundreds of viral sharing events in the particular regions where the risk is highest. And if we manage to decelerate climate change, then we will be able to limit the risk. The risk will still go up with the climate change that we currently have. The climate will change, and let's say temperature will go up for decades, whatever we do. But if we do not move quickly, we will not be able to turn the tide. And we will see a vast increase in zoonotic diseases. We will see a vast increase in pandemics. And we will also see this increase at a time when people live in regions when it becomes more difficult to even meet such a challenge. Because a lot of the regions where you see in that first graph, where you see the future events, there will be dryness, there will be lack of food, there will be lack of work, there will be overpopulation. So if you add all of this together, you are seeing a very worrisome situation which we have to cope. So here is the declaration of the Pandemic Fund. I will not show this, but the Pandemic Fund is something I tend to speak a lot about because this was something I was personally very involved in. But it is also something that I derived from my experience here at the school, I should say. Because what was lacking basically is education of young people who are knowledgeable in that type of technology and funding for their research and funding for their education. That was lacking. And now we have, let's say, roughly speaking, in the first round, we have 350 million available for people who want to do that type of research. It is also research which is available to many of you because you could clearly apply for that type of money if you cooperate with a country where pandemic control is important. So it is money that will be available for many years, and it closes a gap that was here. I move on because time is moving forward, and I look at the UN high-level meeting on universal health coverage. This is also something where you should think, where you may think, well, universal health coverage, this is old hat, all of this has to be dealt with. No, it's not at all. It's not at all. First of all, in the political declaration here, we have 5 clear-cut agendas. Number 1, that healthcare should emphasize the protection of children. You may think, well, this is why everyone will start with children first. Unfortunately, when new healthcare systems are developed, very often children are not put at the top of the agenda. Children very often come last, as a matter of fact. So therefore, to bring up children to the top of the agenda is very worthwhile. It is not what we currently evidence. Number 2, we want to care for the most vulnerable and protect them from financial hardship. You would think, why is financial hardship such an important issue here? Why not simply look at the most vulnerable, no matter what the hardship is? Well, if there is financial hardship for someone who is ill, it's very likely that there is no treatment, and if there is treatment, the family will be so poor that recurrent disease is very likely. So financial hardship and disease is a vicious circle. The disease makes you more financially dependent. Being poorer makes you more prone to disease. Being diseased, again, makes you poorer. So it's a vicious circle that goes around all the time. So to look at those groups where protection from disease also avoids financial hardship is a way to, let's say, stop this vicious circle. Gender-responsive approaches and promote health in women is still a very important issue. In many poorer countries, 70 to 80% of healthcare expenditures does not focus on women's issues. So there is a vast undertreatment here. The One Health approach I've already mentioned before, and ultimately we need to improve data collection and counter disinformation, in particular in the age of social media. So therefore, this is very important. The post-COVID war, in many ways, in terms of, let's say, universal healthcare, is a poorer world in comparison to the pre-COVID time, because over 100 million individuals fall into extreme poverty each year due to healthcare expenses, and almost 1 billion people worldwide are at risk of falling into poverty due to out-of-pocket healthcare spending. So if there is a single major disease for one family member in such a family, the family will be bankrupt. And that is the case and then it is very likely, very, very likely that the treatment never takes place. And if it takes place, poverty will be the result and more disease is likely to come forward. So therefore, that is a very, very important issue. And approximately half of the world's population still lacks access to essential health services, if you think about it. I mean, we are speaking here 4 billion people. 4 billion people are still lacking essential health services. And for most people whom you would ask on the street, no one would guess that in our days that this is still the case. But so therefore, putting universal health coverage on the agenda for the UN is a very worthwhile task. Primary healthcare should be the focus, because very often when you come into poor countries, very often you see that such countries invest in high-end technology, very often indeed to offer that technology for the most affluent people within their country. And while this is very understandable, it is not a good investment in terms of the health of the population. So therefore, in the declaration, there's a clear-cut focus that most of the money needs to go into primary healthcare, because 90% of universal healthcare interventions can be delivered through the primary healthcare approach. So there is a clear-cut focus, and it is important that this is part of the language, because that language shapes what kind of money goes into what projects. And ultimately, if we would be able to deliver that type of care, we would save 60 million lives per year. So this is double the pandemic per year. In other words, basically, we have a silent pandemic, a huge silent pandemic every year, because we don't have universal healthcare. And the cost of, let's say, all of this would be in total somewhere between 200 and 370 billion a year. And if you look at what we do, what we provide in terms of subsidies for fossil energy, we invest per year 7,000 billions a year. So what we speak about here is 3% of that amount, 3% of the amount we spend in terms of subsidies for fossil energy would basically save 60 million people a year. So therefore, the cost effectiveness of this type of an investment would be simply vast. The situation is even becoming worse for universal health coverage, because we are lacking health workforce in the poorest region, and the problem is increasing because the population is increasing more quickly than the number of people working in healthcare. That is a problem, by the way, that we will even have in Europe. In Europe, we have an aging population, but we have a declining healthcare workforce. So Europe will be in the same situation. The number 3 declaration on which I will focus is here, the political declaration on tuberculosis control. We intend to finish tuberculosis as a worldwide epidemic by 2030, and it is still possible. As a matter of fact, we know all we need to know in order to eradicate tuberculosis. We know to eradicate it. So we want to accelerate progress here. We want, first of all, to increase the information, and we want to have a better case surveillance. We need sustainable funding, in particular for multi-drug resistant tuberculosis. In tuberculosis, we are basically in a race. The race is, if we eradicate tuberculosis by 2030, we have solved the problem. If we don't eradicate tuberculosis by that, we will have so many multi-resistant strains that we will most likely never be able to eradicate tuberculosis. So it's an up or out situation, because currently we are making progress in, let's say, moving towards eradication, but the resistance of the strains is developing so quickly that if we are not able to eradicate it in the short run, it is very likely that we will no longer have the drugs to eradicate it at all. So therefore, this is also a very meaningful declaration. The language may be dry and boring, but if you look what is behind it, as a matter of fact, these are major policy decisions on anyone's reading. And if you look at it, we have not been successful. Here in the upper blue line, you see that we have not really been able to reduce the number of new cases per year. We still, roughly speaking, have 10.6 million new infections per year and 1.6 million people dying per year. And therefore, we have to rush forward, and it could easily be done, so we have to strengthen the programs here, and that is a decision that was agreed upon by the UN Declaration for Tuberculosis, which will be finalized, if I'm not mistaken, by today. The other two, let's say, declarations have already been finalized, are already politically consented, and the tuberculosis indeed consensus may come about as I speak, so to speak. So therefore, we have to rush forward here. Ultimately, here you see the distribution. We clearly see that in 3 regions, in India, Pakistan, and in the Russian Federation, the multi-drug resistant tuberculosis cases are coming forward, and we therefore have to focus on tuberculosis control, in particular in these countries. And it is therefore important that countries sign the UN Declaration on Tuberculosis Control that are relevant for that issue. It makes no big difference if we have a G7 declaration on tuberculosis control, because in the G7 countries, you barely see any of the multi-resistant tuberculosis to come about. So we could agree on better treatment of a disease which we barely see, as a matter of fact. But it is only the UN declaration which covers the whole field. Therefore, that declaration is also not to be underestimated. Let me finish up in saying that these issues are very important, very meaningful, need young people, highly qualified people who basically invest their career in that type of work. When I was a student here 30 years ago and longer, I was still lacking the awareness of this type of a research. I should actually say. So I was very number-oriented, I was very technical, so to speak, and the dry political language of such a consensus was not appealing to me. But if I was to enter the field anew, I would clearly try to combine my epidemiological passion and my epidemiological, let's say, ambition with this type of work, because it's a huge opportunity. The next 30 years will be the decisive years for all of the 3 issues I have shown to you. So therefore, first of all, let me thank you for the privilege of being able to deliver this short lecture to you, and let me encourage you to invest your brilliance, to invest your valuable minds and your work in these issues. Thank you.